Hello, I'm Ali, and I think before I begin, I would just like to ask you to maybe just internally have a bit of a think about what your own relationship is with risk. Do you consider yourself to be a lucky person, or perhaps an unlucky person? Do you think you're risk averse? Are you quite happy to take risks, or does that change depending on the situation you're with, or perhaps the people that you're with? Are you very different to the people that you share your life with? Just some interesting things to think about. I'm going to take you through a case study that relates to some broader questions that we think about when we're thinking about introducing new genomic technologies and tools, not just around whether they are useful, whether we've got good clinical utility, but the practical implications and what are the parallel changes we might need to think about in how we explain these tests to the potential beneficiaries so that they can make an informed decision. The average risk of a serious genetic condition caused by a de novo mutation, an apparently new mutation in the individual, is 1 in every 300. That's more common than many people would expect, and we may find that we have more diagnoses of DNMs going forward as we have more whole genome sequencing rolling out. We have the potential to improve, if you like, the information that we give to couples at the moment when they're making decisions about their next pregnancy. So the scenario is they've had a child, testing's been done, the information comes back. We didn't find it in you, and we didn't find it in your partner. We find it in the child. So we call this an apparent de novo mutation. The information we can give you on whether this will happen again, which of course many couples want to know, is a population average figure, a genetic risk figure of around 1 to 2%. Now, I don't know if you would think that 1 or 2% is a high risk or a low risk, but if you're a couple that's already unexpectedly had a child with a serious genetic condition, that may not feel low. Now, there are actually, that figure is made up of different scenarios actually. In many cases, many couples will actually have a negligible risk. It was very likely a one-off event, but there are a small number of families for whom gonadal mosaicism may be responsible, but in standard testing at the moment, we don't know which specific situation applies to a couple. De novo mutations can arrive through different mechanisms, and it may be new in the child, but actually it may exist in one of the parents already, but at a fairly low level, so it hasn't been picked up in standard testing. So that's one of the big challenges. When that change, sometimes we call it a spelling mistake when we're talking to patients, when that change first occurred in the embryo's development is very important because it determines how many different types of tissue in the body that change is going to be present in. And there are very different recurrence risks associated with that. So at the moment, couples are given a 1 to 2% risk, but actually the scenario could be very different, and theoretically the recurrence risk could be up to 50%. So the PregCare study led by Professor Angarelli there and Professor Andrew Wilkie, they were able to create a new type of personalised assessment. Now, this type of assessment, it could be used as personalised prevention. It could just be used to inform so that people could be prepared for the future. That study was able to demonstrate that it was possible to stratify risk into these different categories. And you don't need to take all this in. The only thing I want you to take away from this is that the risk varies depending on which category a trio's test results fall into, but that 71% of cases were paternal one-off mutations. And it's information not commonly shared in clinic. In clinic, they're often told it's out of the blue. There's a very small chance it could be in the sperm or the eggs of one of you, and the conversation doesn't go much deeper than that. So the purpose of the ePregCare study, a lovely team there, was to delve a bit further as to how this might work in clinic and whether it was going to be helpful or not. Now, I'm not going to be able to go into the detail on this, but just what I want to get across to you is how important it is to work out what this will be like for practitioners, what it will be like for people on the receiving end. So we conducted in-depth interviews across the UK, clinical geneticists and genetic counsellors. They had quite a lot to say. And one of the things they did say was that using generic risk felt like a fudge figure they felt very aware they were leaving people in limbo. And when a recurrence does occur, it's a really traumatic event for everyone involved, and they would be keen to avoid that. What they also said was the only tool they had available at the moment to reassure people was invasive testing in the next pregnancy. And there's a number of problems there. One is that people have to take the risk of getting pregnant again. It's not always easy to get pregnant again, but also that not everybody wants to go on that journey of having to think about what to do if the result is not the result they want it to be, and there's a small risk of miscarriage. Invasive testing is only, non-invasive testing is only available if the risk reaches that 10% threshold, but as we've already said, the population risk is only 1 to 2%. They told us, very briefly, that this did have clinical utility. It was great that this could be done prior to the next pregnancy. It could release people from having that invasive testing. But what they also said was there was some ambivalence around maternal origin because we can't access the oocytes, so we can't give a very specific recurrence risk in that context. What they also said was, this is really complicated. How on earth do we explain this to people so that they can make a good decision about this? And I would just draw your attention to absorptive capacity. When couples are in clinic, they're receiving diagnostic information, they're thinking about their risk information. How much can they really take in? And they need to come back to these conversations a number of times. And also, practitioners told us that they were uncomfortable around the sharing the information of parent of origin because they weren't sure, in particular, how fathers were going to react. And they told us that fathers, they felt, were very unprepared for this information. So there was perhaps some changes in the provision of genetic counselling that we needed to think about to prepare them for this information. We have 2 papers out on this if you do have an interest in this area, and you can look more at this here. And these are our next steps. We are going to be interviewing couples about their experiences and how this really impacts on them, because it's one thing to talk to the practitioners about what they think this will impact on couples, but you really need to talk to the couples and work out what they're doing with that risk information when they make their decisions. And also a theatre project, which we're going to be holding here in May, and we're currently in the co-production stage where we are designing a script to a fictionalised journey of a couple grappling with their risk and all the different influences that we all have on our risk, whether it's our parents, our environmental factors, perhaps also our religious beliefs, and how that all interplays with what a couple does with the information that they're given in clinic, so that how they then approach their decision making in the future.